We've been able to have our grand rounds without too many technological hiccups, but if we do encounter some, we'll ask that you please help wait them out. We'll have opportunity to answer questions after the presentation. So during the session, if you have a question, just type it out into the chat box and the moderator will read your question to the presenter during the Q&A session. Additionally, if you would like to ask your question directly, you can always use the hand raise feature in Zoom and you'll be invited to ask your question during the Q&A session. Our moderator, Dr. Kafo, is no stranger to those of us that have joined on previous rounds like this. But for the benefit of those joining us for the first time, Dr. Kafo is one of the brains, if not the main brain, behind the sessions that we've been having. He's a neurosurgeon and currently a neurointerventional radiology fellow at the Mallinckrodt Institute of Radiology, Washington University School of Medicine in St. Louis. Our presenter today is Brendan Eby. Dr. Eby is an assistant professor of neurology at the Washington University School of Medicine. He's a board-certified neurologist and vascular neurologist. He obtained his medical degree in 2014 from the University of Alabama School of Medicine, Birmingham, Alabama. In 2018, he completed his residency training in neurology at WashU in Missouri, and went on to pursue a subspecialty fellowship training in vascular neurology at Emory University, Atlanta, Georgia, which he completed in 2019. Dr. Eby completed another fellowship training in neurointerventional radiology at Emory University in 2021. We are delighted to have Dr. Eby here today, and we look forward to a fantastic session. So over to you, Dr. Eby. I hope I got your pronunciation correct.
Oh, it's all right. I actually say Brendan Eby, but I appreciate that.
Okay. All right, Dr. Eby. Sorry.
And I really appreciate the kind introduction. Yeah, so I'm Brendan Eby. I was asked to talk about extracranial angioplasty and stenting. Most of this talk is going to be focused on carotid disease because that's where we really have the evidence. But he's already kind of gone over a little bit of my background, but as is common, I wanted to make sure I included my disclosures, which include, I am both a vascular and interventional neurologist at Washington University. I did neurology training and specialized in stroke, and then additional training in intervention. So I work very closely with Dr. Okafu. I am an assistant professor here in the Department of Neurology, and by courtesy also in neurosurgery and radiology. But I'm also the director of one of our smaller stroke centers, the Barnshire St. Peter's Hospital, which we have come online as a stroke thrombectomy center, so for interventions. And we're also performing some of these procedures, particularly the one that we're going to focus on in the talk today, carotid angioplasty and stenting. So in a similar sense, some experience about bringing this out to a population that hasn't had it before using some of the newest technology. The only financial disclosure, I did a talk for a device company at their national fellows meeting. I guess it's almost been a year ago. And in this talk, I will use a couple of brand names or show some examples for some of the devices that we use. And this is really just for reference. I'm not advocating any particular device or company. There are a lot on the market, but this is just so that you guys get some tangible idea, kind of what we're talking about. When I was talking with Dr. Okafu, just preparing for this talk, trying to get an idea of what is going to be useful, I realized that when we talk about stroke and carotid disease, carotid intervention is a common place of discussion and somewhat debate in the United States. But he enlightened me that it's not as common either diagnosed or intervened on in other parts of the world, including Nigeria. And so I just want to make sure that we spend some time making sure we're going into depth on what the problem is and the evidence so far. And so a lot of this is likely going to be a little bit of a review for anybody who's familiar with this, but I just want to make sure that we're kind of speaking a common language when we talk about particularly carotid disease, what carotid stenosis is, how we diagnose it, treat it, and otherwise management. And that obviously comes first with, talking about stroke. This is a worldwide problem. You guys are very familiar. but 12 million strokes a year in the world, with over 110 million people who are survivors of stroke. Stroke is one of the biggest problems, and it is a leading cause of death, both in the United States and throughout the world. But it's actually one of the major causes of disability. A lot of people survive their stroke, but it takes them out of the workforce. They can't contribute to home. It becomes a tremendous burden. And so doing the things that we can to help people recover from stroke and prevent more stroke, I think, is very important. And then when we talk about stroke, obviously, there are a lot of different types of stroke: ischemic and hemorrhagic stroke. We're going to be focusing on ischemic stroke here, which does make up the lion's share of stroke. 87% of strokes are ischemic. A lot of this talk is going to be biased towards the United States because that's where I practice, but we still see a very large amount of stroke. This is a common problem across developing and developed nations. And in the United States, that's no different. We are well known to have high rates of stroke, particularly in the southeastern United States. You can see from the color coding on this map, the dark purple highlighting that area. St. Louis, Missouri is just on the north end of this area. So we still see a significant amount of stroke, but all of my additional training, as mentioned, was down in states of Alabama and Georgia. So right in the middle of the stroke belt. And, I was able to appreciate with my training how difficult this disease really is. And, in a similar sense, I just want to make mention, a lot of my information gets consolidated from, we have some practice guidelines, both for just prevention of stroke in general and for carotid and extracranial stenosis management. So these are kind of the position statements from some of our American-centric societies. And so a lot of the references here will refer to that, but there are a lot of different recommendations throughout the world. Most of them are in keeping with the same advice. And so I think it's a good representation. But if you have something locally to reference, that's also important. So, stroke is a big burden, and we know that atherosclerosis is a leading cause of stroke. And so that's a focus here when we're talking about specifically atherosclerosis in the carotid arteries. Atherosclerosis throughout the cerebrovascular system attributes to stroke and is probably the majority of strokes. This can be intracranial or extracranial large vessel atherosclerosis. This is also very commonly small vessel lipohyalinosis. And all of this comes with many of our modern diseases: obesity, sedentary lifestyle, smoking, as well as hypertension. I didn't list it here, but diabetes is also a common comorbidity. These are risk factors that cause, atherogenic state and the buildup of this, these atheromas in the blood vessels. In addition, I think those are kind of the modifiable risk factors, but genetics and the older aging population is a risk factor for these problems. So that shouldn't be overlooked. This is still going to be an issue, even with a healthy lifestyle in a certain portion of the population. And so then keeping that into account, we talk about atherosclerosis in the brain, but particularly extracranial atherosclerosis still provides a majority of, or not a majority, but a large portion of ischemic stroke. So up to 15% of ischemic strokes can be attributed to extracranial atherosclerosis. And that comes from a variety of mechanisms. The most common is probably thrombosis. It can be acute occlusion of the vessel extracranially, but a lot of times this is actually more of like a thromboembolic picture where the clot forms on the atherosclerotic plaque, but part of it embolizes distally into the brain. And then in some cases, there can also be just a hemodynamic mechanism, either partially or completely, where it is so severely stenosed, there's limitation of blood flow to that hemisphere. And it's probably a complex interchange between all of these mechanisms. but ultimately it results in, a significant rate of stroke. And then the biggest issue that has been well known for a number of years is that this also leads to a very high rate of recurrence of stroke. So we have some images here, just some lateral angiograms of the carotid. You can see the common carotid coming up and the internal carotid artery marked as the ICA here, where there's severe stenosis at the origin. That's by far the most common location for this atherosclerosis. And even on the image on the right, you'll note that it's so severe that it's caused some distal caliber changes. The carotid has kind of collapsed down. Some people refer to that as near occlusion or string sign, and that can be a common finding. And when we have this severe stenosis or even moderate stenosis, the rate of recurrence of stroke is very high, between 18 and 22%, as I've listed here on much of our pooled analysis. But when I say moderate and severe stenosis, I just want to take a minute to make sure that we're talking about the same language, the measurements. And so we kind of categorize this based on the degree of stenosis, and the gold standard is that angiogram that I showed you. And there are a couple of different ways that you can measure it. For what we're describing, and most of the literature right now and recommendations go on this North American Stroke and Carotid Endarterectomy Trial criteria, or NASCET. But there's also a European Carotid Surgery Trial, ECST criteria, that some people will refer to. And so just to make sure that we're speaking the same language, for the NASCET criteria, you take the distance of the lumen, the open part of the artery at its nearest area, over the width of the distal carotid, what should be essentially normal for that artery. And you can get an idea of the degree of carotid. For the European trials, they were using this other measure where they were trying to estimate the width of the carotid at the area of the stenosis. And going back to the image from before, you can imagine there's some issues there, really knowing where the edge of that carotid ends on subtraction angiography. A lot of times that atheroma also pushes out the vessel. You can overestimate in some regards. I guess I shouldn't say overestimate, but the ECST has a tendency to have higher stenosis measurements. NASCET tends to be a little bit on the lower side. So when I'm talking about degree of stenosis and severity, it really goes on this NASCET criteria, where mild is less than 50%, moderate is 50 to 69, and severe stenosis is 70 to 99%. I heard some talk. I just want to make sure there aren't any questions.
No, there are not. You can continue.
All right, I'll keep going. All right, so we're talking about degree of stenosis, and we know that depending on the degree of stenosis, that results in a very high rate of recurrent strokes. So how do we diagnose the stenosis? Well, when people come in for workup of an ischemic stroke, we routinely get vascular imaging, but there's a number of different ways that you can do it. The gold standard was carotid angiography. And it probably does give you the most detailed analysis, of the degree of stenosis, but it is very expensive and also invasive. So that is by far not the most common at this stage. And what is most frequently used is carotid ultrasonography. So an ultrasound, it can be cheap, it's portable. But the biggest limitations of it is it doesn't actually visualize the degree of stenosis. It's a flow-based measurement. Try to see the degree of increased flow and therefore correlating to further stenosis in that vessel. And therefore, it can be very technique and technician dependent. It also doesn't have high resolution. So ultimately, it can only stratify within these groups, no or mild stenosis, moderate stenosis, severe stenosis. We can get a lot more detail through non-invasive other imaging, so CT angiography and MR angiography. They have their own limitations. CT requires contrast, it requires some radiation, but it is a very good test, and it also gives you an idea of the extent of the carotid artery. So atypical pathology, when it's not specifically at the carotid bulb, then you can also pick up on kind of what's going on. And the same is true for MR angiography, but that has the limitations of MRI. So retained metal fragments or other people that can't get the MRI, but it doesn't require radiation. And the MR angiography can be done with and without contrast. And kind of comparing them all, it seems like they're all reasonably effective, but there are some, I think, key considerations. So this is a nice paper out of Lancet, meta-analysis, looking at these different types. Doppler ultrasound, CTA, MRA, contrast-enhanced MRA, and their sensitivity and specificity in each group. And you'll see, particularly in severe stenosis, the sensitivity and specificity is actually really pretty good with all of them. Ultrasound is upper 80s%. If you get to a contrast-enhanced MRA, it's in the 90s. And the same is also true with no significant stenosis, less than 50%, 80s to 90s%. Where there's a lot of kind of discrepancy is in that middle range, that moderate stenosis, where the sensitivity for both the ultrasound and the MRA is actually quite poor, less than 50%. So, 36 and 37% respectively. And CTA and contrast-enhanced MRA does a better job there, but they're all relatively specific. When they think, when it shows some stenosis in that range, it's usually fairly accurate. So in our practice in the United States, particularly at Washington University, we usually use the ultrasound as the first line kind of screening technique, but we do like to confirm it on one of these other tests. And so that can be a CTA or an angiogram, depending on the patient's situation. So you have a patient that came in with a stroke. You are worried about their extracranial carotids. You've done one of these tests and it demonstrates some narrowing. Well, the next thing that we obviously have to establish is that there's something that we can do to try and prevent another stroke. Intervening actually reduces the risk of stroke. And so before we get to angioplasty and stenting, I need to speak on carotid endarterectomy because that was the first intervention that was really tested. And it did show kind of a robust reduction in the risk of stroke. These are some of the early trials, the North American symptomatic carotid endarterectomy trial with the NASA trial that I referred to earlier. That's a trial out of the 90s. So, this data is a number of decades old now. And this pooled analysis also includes European data and stuff from our Veterans Affairs VA, showing robust treatment effects. So this is kind of the risk of ipsilateral stroke, operative stroke, death. The dark bar is for the treatment arm, so carotid endarterectomy. And then the thin bar is for medical management. And you can see, particularly on the right side of the screen, these are for severe stenosis. And you can see almost immediately there is a substantial reduction in the rate of stroke and death. And that maintains quite a separation throughout the whole 5 years of follow-up here. In the middle is moderate stenosis, 50 to 60%. And the benefit is a little less clear. There's an early actual increase in risk when it comes to surgery, probably attributable to the surgical risk. But over time, there's still this robust suppression of the rate of recurrence of stroke. And so these graphs the lines do depart and they stay apart, at the end of the 5 years. Whereas in the mild stenosis, less than 50%, there's no real separation in these lines throughout the whole course here. There's no significant difference here. And so the evidence is pretty strong that in severe stenosis, this is a recommendation. In moderate stenosis, it likely does benefit, but some patient-specific factors might change that, if they really can't tolerate the surgery. But this intervention is not recommended in minor stenosis. And so, this talk is supposed to be about extracranial, like angioplasty and stenting, and the use of endovascular treatment. But why am I talking about carotid endarterectomy? Well, once this came out, this became standard of care. And so everything going on is actually compared to carotid endarterectomy. because especially in severe stenosis, this is indicated and recommended. But, these are kind of the two major ways to intervene that we talk about. I'm sure you might be familiar, but when I say carotid endarterectomy, this is a surgical procedure to clean out the artery, essentially. There's an incision made on the neck, dividing down to the carotid artery. Typically, there's clamping of the carotid artery, and then an incision is made, cleaning out the necrotic, lipid-rich core of this plaque, and then sewing the artery back up. There are a number of additional surgical techniques that can be debated, whether or not you put a patch graft back, whether or not you reroute some of the blood supply during the procedure with a bypass. But in essence, this is the basics of the procedure. But then with the advent of our endovascular techniques, particularly what they were able to do in the cardiac side of things and cardiology, people developed techniques to be able to do this more minimally invasive, so endovascularly. And so that's what's featured here on the right side, carotid angioplasty and stenting, where a wire is placed up. Here it's showing a distal embolic protection device, which I'll talk about. A filter is placed, and then across the stenotic lesion, a balloon can be inflated, and the stent is then placed to reconstruct the lumen and provide a scaffold for the neo-intimal growth and endothelialization, basically, a functional healing of the artery. The atherosclerosis is not removed, but it is excluded from the circulation. And so comparing these two, if we know carotid endarterectomy works, does carotid angioplasty and stenting work as well? Does it work better? And there have been a number of trials that have included both of these as arms. And so here is a review meta-analysis that was published in 2021, an update of all of that. And essentially, there are differing risks between the different procedures. It seems that, but on overall, you can see from the meta-analysis, a lot of these confidence intervals, on the right, it's favoring endarterectomy, on the left, favoring stenting. The confidence intervals cross the midline. But overall, for the risk of stroke or death in the follow-up population, there was a tendency towards favoring carotid endarterectomy with an odds ratio about 1.7. So a slightly increased risk of complications from stenting than endarterectomy. That ends up being about 6% when it comes to stenting versus about 4%, particularly of recurrent stroke. Interestingly, if you dig into the data a little bit more specifically, it gets affected by a number of things. Age seems to be the biggest modifier. So patients over 70 have an increased risk of problems, particularly stroke, with stenting. And that's 2.2-fold increased risk. But if it's less than 70, there was no significant difference. The odds ratio of 1.1. Actually, in a subgroup analysis of patients less than 60 years old, it seems like they actually did better in stenting. That's particularly with the CREST study that was mentioned here at the bottom of the graphic. And then carotid angioplasty and stenting has some benefits. It was much lower risk of a heart attack during the procedure, as well as cranial nerve palsies, or even access site hematomas, which is interesting, I feel like, because we do worry about that anytime we do an endovascular procedure. We're going in the artery, but an access site hematoma in the neck can actually be very serious. So overall, the idea was that stenting has a combined increased risk of stroke or death. But then if you take out the specific operative risks, there's no increased risk compared to carotid endarterectomy. That's the very last point on the slide, where the odds ratio is 1.05 for that first 30 days. Presuming in an appropriately selected patient that you're able to do the procedure safely, it is a robust treatment, it reduces the rate of stroke, and it seems to be just as efficacious in the long term. So it's really more about the specific patient if there's factors that are increasing the risk. Now, that's when they tried to look specifically at high-risk patients. So, it being worse in an older population, there are a lot of debate about that. I think most people in the field feel like a big representation there is just that that represents more difficult endovascular techniques. These patients are more risk during surgery as well, but it seems like the risk is increased faster for endovascular procedures. More tortuous anatomy, more atherosclerosis throughout the vessel. So if you're traversing from the femoral artery all the way up to the carotid artery, there's more of a risk that you're going to cause some issues. And it's not terribly high, but it is worth noting. So in the United States, the recommendation is for carotid endarterectomy as the first-line treatment, and only if there's a feature that makes it high risk for endarterectomy that we talk about stenting. And when I say high risk, that mainly comes from this trial, the Sapphire trial, where they did angioplasty and stenting versus carotid endarterectomy in these high-risk patients and they only used a distal protection device. And this showed substantially reduced risk of stroke or death with stenting over endarterectomy. Here you can see 12% versus 20% in the surgical risk. And so these are the features considered high risk. Severe cardiac disease, as I mentioned, the endarterectomy has a higher risk of MI. Pulmonary disease, contralateral carotid occlusion. During the CEA procedure, they have to clamp the carotid, so there would be concern for poor perfusion if the other side is also occluded. Contralateral laryngeal nerve palsy, there's a much higher rate of cranial nerve palsies with the surgery, or radical neck dissection or radiation therapy, something that makes the neck more difficult to operate on. And then recurrent stenosis, if you've had this operated on before, that would be an indication to try and reconstruct the lumen with a stent. So the current recommendations for most in the United States and what's actually reimbursed by our insurance, unfortunately, a lot of times can drive some of our management decisions, is that CEA is kind of first line stenting for these high risk patients. And because this trial used embolic protection devices, we are recommended to use embolic protection devices as well. And so outside of that, it really comes down to a patient-specific selection. We can talk about the pros and the cons of both, but one of the major advantages of carotid artery stenting is that it's a lot more minimally invasive. It's just small, incision above the artery. Recovery time is very minimal. It's usually just one night stay in the hospital. People can return to their daily lives very quickly. The risk of blood loss and some of these other complications are very low. I will note, anytime we place a stent, very similar to, anywhere else in the body, we do put patients on dual antiplatelets. Our typical course is aspirin and clopidogrel for about 3 months after the procedure. There's some alternate antiplatelet agents, but it does require dual antiplatelets for a short period of time. And in some patients, that can be a concern. We talked about the peri-procedural risks, and then there can be, specific challenges. Some patients just have much more difficult anatomy, various, variants that just makes it more challenging. So, we've kind of talked about what establishes, when to take these patients, but part of this talk was also to talk specifically about how this procedure works. Here's a nice little summary that I pulled from the Journal of the American Medical Association, just a graphic, and I probably could just give out this slide as the basics on this entire talk, but it does a really nice job kind of discreetly putting it together. Access is gained to the vascular system, usually from the femoral artery. We do have some experience doing radial artery stents. It makes the anatomy a little more tortuous. That's just more technically difficult, but in some patients, that's the appropriate maneuver. But usually the femoral artery, we bring the catheters up, under X-ray guidance, and then we're dealing with the stenosis in the neck. You can see the demonstration of high-grade stenosis. when I talked about distal protection device, that's going to be on the next slide. But usually that's placed first. The whole idea here is that during angioplasty or stenting, there's a risk of loosing part of the atheroma, and causing an atheroembolus. So this would be some sort of protection to try and prevent that. Typically, angioplasty is pursued first, so the balloon is then inflated. These are non-compliant balloons. In other words, they tend to open the same width along the entirety of the balloon. You're trying to reconstruct the lumen, so you want the whole area to open to the same degree. And then placement of these self-expanding stents to incorporate across the whole artery and reconstruct flow. Based on that Sapphire trial and the use of embolic protection device, the recommendation is to use embolic protection device. And I mentioned that we were going to talk about that on the next slide. Some of the early versions here or distal occlusion with the balloon. This had a lot of problems. As you can imagine, if the concern during surgery is clamping the carotid, here inflating a balloon and blocking flow is also a substantial concern. During these procedures, we do heparinize. So we give heparin to maintain, an activated clotting time, probably between 250 to 300. Different protocols vary slightly, but that's the goal. But even still, with the balloon up, there's a risk of embolus. And so other protection devices were designed. There's a proximal occlusion, which is shown in the middle of this left side graphic, where a balloon is placed more proximally, and then also another balloon in the external carotid artery to prevent retrograde filling from there, so that you can actually reverse flow in the ICA. Basically, if you break something off, you can suck it into the catheter rather than send it to the brain. This also has the concern because it limits blood flow to the brain. And so by far the most common at this stage is a distal filter. And the picture on the right is the one that we commonly use. There are a lot of different types, but this is the Spider FX. It really is just this small basket. You size it to the size of the distal carotid artery, and it opens and provides a filter. It doesn't occlude blood flow. You're still maintaining perfusion, but should you break something loose during the procedure, hopefully this would be your backstop to be able to catch it. And then once this basket is up, this wire is exchanged outside of the body. And so unlike a lot of our other neurointerventional procedures, this procedure is done usually exclusively in what we call rapid exchange style. So here is one form of balloon, the Sterling balloon. This is what we typically use at our institution. But all the balloons tend to be very similar, where the wire actually enters this mid portion, the side port. You can see right in the middle of that top graphic. So the balloon runs along that wire, and so we can use that same wire from the filter device that has maintained access across the stenosed lumen, bring the balloon up, and then using graduated inflation, we will expand the lumen of the vessel. And that's typically sized. Again, the goal here, if you go back to the NASET criteria, the goal is to reconstruct what is similar to the distal carotid. We're not trying to, widen the bulb any further than what the carotid artery looks like distally, and increase, improve the flow to what is, normal. So it's sized to the distal carotid artery. The balloon comes first. And then there are a variety of stents and a lot of discussion about the type of stent. Down at the bottom, you can see all the different styles. There's some closed cell stents where all of these lattices are connected. There are open cell stents, like the example on the far right is the best example, which gives a little bit more play in between each of the lattices and allows it to potentially expand to differing anatomy around curves, or if there is a big taper. But at the end of the day, they've all been somewhat tested, and approved for use, and they seem to work very similarly. And their delivery mechanism is the exact same, rapid exchange. So, the tip is slid along the wire, it comes out of the side port, and then you ride it over the wire and position it across the stenosis, where you're able to deploy the stent. It's usually kind of an unsheathing or withdrawing to allow it to expand into that segment. And in certain situations there, you might need to go back with a balloon through the stent and do, a post-processing angioplasty to allow good apposition and make sure that you've expanded that segment. And so to give you guys an idea of what this looks like, in practice, I do have a quick case example. And so this is actually a gentleman that Dr. Okafor helped me with, I believe just last week. And so it's a gentleman that came in, he's 67, and he came in with these watershed or border zone appearing strokes on the right hemisphere. So this is diffusion restriction on the MRI on the axials, and you can see kind of in an ACA, MCA distribution, he's had these acute infarcts that show up bright. And then we did vascular imaging with a CTA. He had a high enough stroke scale. This is very routine that we do a CTA to look for thrombectomy candidates and intracranial large vessel occlusion, but it is standard for us to extend that protocol to extracranial as well, both to look at the carotids and to see if there's any other cause of the stroke. And so here you can see on the lateral view, his right internal carotid artery shows an area of short segment of severe stenosis with some calcifications in the wall. So very stenosed, as pointed out with the arrow. And interestingly, this is a bit distal to the carotid bulb and the takeoff of the external carotid artery. You can see that just at the bottom of this image. And so we took him to angiography, and that's exactly what we confirmed. So here on the initial imaging, we have an AP and a lateral view where the carotid bulb is widened, and then there's an area of pretty significant stenosis prior to the kind of maintained caliber of the distal carotid artery. You can see our guide catheter down at the bottom. And then over on the right side of the screen, this is us doing some automated measuring. You can do this manually, but our software allows for some automated measuring. I usually confirm myself, and it's actually quite good. But where we're measuring across that most stenotic lesion down in the middle, and then you can see up at the top labeled D is kind of more of the distal internal carotid artery, so that we can get that NASIT measurement. And this was borderline severe stenosis, so 69%. And so because of some medical risk factors, particularly active coronary disease, we felt that stenting was the appropriate management for this patient. And so we pursued that. Here you can see this is what the angiogram looks like during the procedure. So we've placed the filter basket as labeled with the arrow up in the distal carotid artery. You can see the distal wire marker at the very end. And then you can potentially make out the small hoop of the bottom of the basket extending across the carotid. And then the wire extends down into the carotid across the stenosis, where we've advanced the balloon over the wire. And there are two markers, a distal and a proximal marker across that area of stenosis. And I believe this image is actually after our first angioplasty. There's a little bit of movement artifact across that, so you can see that streak. It makes it a little harder to see. But angioplasty is pursued, so we crank open the balloon, and then we ride the stent up over that same wire. So in the next two pictures, the filter is still in place, and then you can see the stent tines as marked on the right side of the screen as it extends in that lattice work. And the advantage of that self-expanding stent, distally it is well opposed, it comes across that stenosis, and then the key here is that you're also sizing to your proximal landing zone, so where you're putting that stent proximally. And there's a big step off here, so we used a if I recall, this was an 8mm distal and a 10mm stent transition stent, where it would be well opposed to that proximal segment, and those tines look like they've expanded really nicely here. And so we do have the post images now. The filter wire was recaptured under X-ray guidance, and then you can see the difference in that particular segment of severe stenosis. And the emphasis here is that we're not trying to reconstruct the carotid bulb. We're trying to reconstruct the distal carotid again. So this doesn't show any significant stenosis distally and is, good coverage in that area. So, that's what we do with the carotid angioplasty and stenting. They're sent for recovery. Usually this is done under moderate sedation, so you can get an exam essentially immediately and make sure that there aren't any complications. And then it's mainly groin site management. There are some concerns for reperfusion for all of these, a risk of labile blood pressures. A stent in this carotid body for some people can cause some bradycardia, just like a carotid reflex. Some of my colleagues will preemptively give glycopyrrolate or have atropine in the room in case that becomes more dramatic. Some people have had severe bradycardia or periods of asystole when the balloon goes up or when the stent first goes in. Almost always these resolve before leaving the procedure room, but it is something worth monitoring. And then in the long term, there's also some chance for reperfusion problems. For people with severe stenosis who get either treatment, a very small subset can have some issues with cerebral regulation after this and can cause like a dramatic increase in blood flow. And for a small portion of these people, that can cause a hemorrhage. So we monitor them routinely overnight after this procedure. And we don't have good indicators right now exactly who suffers that, but we're very strict about blood pressure parameters and making sure that they're within a normotensive range after the procedure. I did have one slide that I wanted to mention on vertebral disease, because the talk was extracranial angioplasty and stenting, and basically I only talked about carotid. And the short story is that we don't really know what to do with the vertebral arteries. There is a stenosis that happens there as well that likely contributes to stroke, a number of strokes, posterior circulation strokes. We don't have the randomized trials to prove that intervention in this area really helps or what techniques. So there's a whole variety. At this stage, I think that it is considered. So you can see in the graphic like this osteal stenosis, like frame B, they're showing that there's some stenosis at the origin of the vertebral artery, which is the most common place. And some people, there's techniques described to place a balloon and a stent in that area too. But exactly what type of devices and which patients to take, we don't really know. And so in that regard, it's really reserved for people who have recurrent disease that we really feel like it is due to this, that have failed maximal medical management and are worth more of an aggressive intervention. Maybe in the future that we will have some more guidance here, but really most of our evidence is based on the carotid literature. And so here it's a lot more limited. And so with that, I can post my references and I can take some questions. I see, actually, I think there's one question in the chat. Somebody was asking about the software that does the automated measuring. So we use a Siemens biplane angio machine, and they have a quantitative vascular analysis, which is a software package within their digital subtraction angiography software. And so the one that I had shown was specifically on the Siemens biplane machine. I'm fairly confident most major manufacturers of angiography equipment. So I used Philips previously at my last institution. They also had their own type of software that would automate some of these and try and assess just based on density where the lumen ends, and then you can select distal and proximal stenosis, and it will calculate automatically. Hopefully that answers your question. Are there other questions that I can answer?
Dr. Bankley, are you still there to progress the meeting?
Mhm. What? Brendan?
I think your audio is not very clear, Dr. Bankley.
Can you hear me now?
A little better.
Okay. Well, thank you, Brendan, for that fantastic presentation. I'm going to open the floor up for questions. Dr. Kafo, you can take over. I hope your audio is better than mine.
No, it's much clearer now. Thank you. I want to thank Dr. Ibai, Brendan Ibai, who happens to be one of our trainers here at the fellowship here in Washington University in St. Louis. I really enjoy working with him. Thank you so much for that wonderful presentation. Dr. Bankley, thank you so much as well for all this hard work on these grand rounds. To be honest, we're really excited about the future, what the future holds. We're working with a lot of stakeholders to facilitate world-class comprehensive stroke care in Nigeria, which is the goal of these grand rounds that we've started, and possibly the rest of West Africa. We just want to say at this point that more information hopefully will be forthcoming in the future with regards to opportunities for anyone who will be interested in engaging with this much needed work. I mean, just to confirm with Dr. Banko, I know this is not even being offered at all in the whole country. And I'm sure there are people with carotid disease that will benefit from revascularization to reduce the stroke risk and burden as well. I don't know, are there any additional questions or maybe comments? We have some expert faculty as well on the line who might want to chip in. We finished a little early. So if you want to make any comments.
There's a question in the chat.
Oh, okay.
Question in the chat. Is there a role of computational neurosciences and AI in the future of stroke management? I feel like that would be a great discussion point for the whole group. And is a very broad question, you know, is there a role for AI in stroke management? And I mean, I think the answer is absolutely yes. I think we're just scratching the surface on what we're able to do with computational models and, you know, effective AI. The most common that we encounter right now in the United States is there was a company, Viz AI, that led the charge on large vessel occlusion detection. So that's not in keeping with this talk, but for thrombectomy, analyzing a CTA and then being able to detect whether or not there was a large vessel occlusion, one that would potentially go for thrombectomy. And that is also met with CT perfusion, which has been a kind of a mainstay for the last few years for selection, where we try and see how much penumbra, how much of the brain is missing blood flow. And then, you know, the ischemic core, how much damage has already been done. And so in combination, allowing the computer to detect this, and then will notify us. And so Viz AI was the first company, but then many of the other companies have brought on similar modules. So we use Rapid. It's another company that has the same kind of detection, that much quicker than a radiologist, well, not necessarily quicker than the radiologist, but it can happen immediately after the scan is uploaded and there's no human delay. And they can evaluate the scan and then page out that they suspect they see this large vessel occlusion and try and cut down on time. Whether or not you believe that that's actually AI is a debate, though. That's just image processing. That would still be a very nice role here with the carotid disease. I'm sure a lot of people are trying to design it. It's more difficult because these lesions just can be a lot more variable, but being able to detect carotid stenosis and alert us, you know, basically offloading the work of some of the radiologists, I think could be helpful. Where I really see like computational neuroscience improvements is if we can incorporate this for some sort of prediction model. So like risk factors, the background of the patient, the likelihood that they have atherosclerosis or that's contributing to their stroke, and therefore whether or not we should be intervening on it in these situations. and other things, which medications are going to be most effective. I think being able to tailor specific therapies for each individual based on all of their, multifaceted risk factors is going to be probably the most helpful from stroke. But there are a lot of smart people, and I'm sure they're going to come up with really cool things to do with it.
Thank you, Brendan. There's another question in the chat box, which I think would probably just pose to Dr. Bankole. It says, is carotid endarterectomy performed commonly in Nigeria?
Okay, well, I'm happy to answer that, but there's also one or two questions earlier on about what software.
Oh, that's been answered.
Answered, and then there's another one. Okay, as far as computed carotid endarterectomy being done, I would say no. Not to my knowledge, I'm not aware of anyone that does it. Definitely, we have people that have carotid disease, but we do not have anyone doing carotid endarterectomy to the best of my knowledge in the country at the moment. But somebody else in the audience has different information. I'll be happy to hear about it. I know Professor Ginny, you are on here. I don't know if you have any comments or questions.
We still have room for a few more questions or comments from anyone.
Well, I think my comment all has to do with the hidden burden of disease of stroke that we sort of know is out there. And well, I don't know if excited is the right word, but I can only imagine if when we do start doing some of these tests and screening and actually doing measurements, what we'll begin to see, because currently what we tend to see are only the ones that do present to us in Luth or the tertiary hospitals, which, as you said at one or two previous ground rounds, are definitely just the tip of the iceberg. And I can imagine that when we start doing screening tests and having proper angiography material, equipment and tests done, what we'll get to pick up and how that can help modify the stroke rates of people down the line before things get too bad. So I think that would just be my comment on that. But apart from that, really fantastic presentation. Thank you, Brendan, once again.
Brendan, I just wanted to just ask a question. I think you've already alluded to it, but just to make it clear to the audience, what patients would you consider will be or would serve as like contraindications to the surgical arm, the carotid endarterectomy, and would rather benefit from just angioplasty and stenting?
Yeah, so yeah, there was a slide, I could potentially bring it back up, but essentially, interestingly, young patients actually do pretty well with carotid carotid stenting. And so, that actually, I think, would be a consideration. I mean, I think they could do just fine with stenting. The older patients do a little better with carotid endarterectomy. But as far as high risk for carotid endarterectomy, the things that we definitely think are high risk are when it's a kind of a, as some surgeons would say, like a hostile neck. There's, features to make surgery more complex. So radiation, previous scarring, and other things that make the procedure higher risk. So a contralateral occlusion. So if you're clamping during carotid endarterectomy, then they have occlusion on both sides. Or if you have recurrent laryngeal nerve palsy on the other side. So if the larynx is closed on that side, and then you were to injure the one on the ipsilateral side, then they could have stridor or breathing difficulties. And then, another one that we've started encountering a little bit more with our aging population is people who previously had a carotid endarterectomy. So they've already had an intervened and surgically manipulated carotid, and that becomes much more difficult to have to go back in and try and excise another atheroma. And so by, a lot of times we defer to stenting. Recurrence within a stent is another reason for another stent. You wouldn't be able to get through the stent surgically. And so somebody who's had a stent placed before, those are things that we, definitely push us towards stenting. But then the other is just the medical health of the patient. It is more minimally invasive. We can do it under moderate sedation, and I do all of mine under moderate sedation to try and avoid the risks of anesthesia. And so if they have cardiopulmonary disorders, COPD, longstanding smoking history, or they have significant cardiac disease, these are patients that do poorly, have very high risk of a major vascular procedure and under general anesthesia. And so this is where the minimally invasive part of the stenting can be a real benefit.
Thank you very much. So maybe in the absence of any other, okay, a few questions coming up here. It says, there's a question from I think it's Dr. Naji Fezia, says, what efforts are the Nigerian neurosurgical world making to garner the necessary expertise and resources to begin to screen, diagnose, and carry out some of these neurosurgical procedures that are not being done in Nigeria presently? Over to you, Dr. Bankole, once more.
Well, thank you, Dr. Naji. Well, I think this is one of the efforts that we are making, which is first of all to raise awareness and get information and knowledge about it. And like Dr. Okafor sort of alluded to, the whole premise of us having this ground rounds is two-pronged, at least. One is to the academic side and just to teach and let people learn things. But on the other hand, we are also working, trying to collaborate with other stakeholders, both locally and internationally, to try and make these services available in the near to intermediate future. So there are some efforts being done, at least that I can speak to directly, as to what the whole society, neurosurgical community in Nigeria is doing. I may not be able to speak to that too much, but this is definitely one of the things that we are doing. We are working on it, trying to get the equipment, and we are looking for people who can partner with us to make that possible. Thank you.
Okay, so I'll just hand over to you to round us off, Dr. Bankole. Thank you so much for everyone who's joined us. Dr. Bankole, do you want to round up for us this last comments?
Yeah, sure. I muted myself again. All right.
Yeah.
Well, I mean, on the screen, I think we can all see that our next ground rounds will be on the 12th of April, 2023. So please feel free to use the screen, the flyer on the screen for details, and to also inform other people who you think may be interested. Do invite your colleagues, and if you have ideas for other topics along these lines that you want to see presented in future ground rounds, kindly contact Dr. Okafor or myself. Thank you once again for joining us. We hope this has been valuable for you, and have a good rest of the day. Enjoy.
Thank you, everyone.
All right, thank you, everyone.